I was asked to talk about delivering effective feedback. And when I started thinking about that, after almost 35 years in nursing education, we spend a lot of time giving feedback. But I really had to kind of think about what I believed about delivering effective feedback in order to kind of put that in my head. So these are kind of my premises. I think that if we're going to be effective with preparing healthcare professionals, our clinical's got to be effective. So effective clinical evaluation is imperative for that healthcare discipline. We've got an obligation to graduate proficient practitioners. So there's a lot of pressure not only on the student, but the faculty as well. We do know that excellent clinical experiences are vital to a practice discipline, whether that is nursing, radiology, medicine. The quality of the clinical experience is directly related to the proficiency and the effectiveness of that graduate when they finish. Clinical teaching is hard work. Everybody has been involved in that in some way. There is not a lot of monetary value that goes along with that. So a lot of that is that intrinsic joy that we get from that clinical teaching. How to provide effective feedback is not something most of us are taught. It's not included in any healthcare program, and all of a sudden you find yourself in a teaching role and you've got to mentor and provide guidance for somebody else. And no one's told us how to do that right or how to do it wrong. And a lot of times what we find is what we do is we perform like how we were taught. And I don't know about you guys, but there were a lot of things that happened to me in my educational program that I really don't want to share. I would not like to emulate and repeat the red card citation. If you did something wrong in clinical, you got a red card. Occasionally you got a blue card, but you got written up on a red card. Intimidating. Before you're able, as an instructor, to provide feedback, you really have to assess your readiness to be a preceptor or to be a clinical instructor. And I think those are hand in hand. So you really have to know, are you ready for that role? And when we talk about the students being ready, the students coming prepared, I think we have to flip that around and look in the mirror and ask if we're prepared, if we know what we need to know. And so I have a whole list of questions and then sources for answers. Now, can you see that? I was trying to pick out a color that would be effective, but you could see, you just never can tell. First question, do I have the knowledge, skills, and the ability to assist the students? How are you going to know that? Certainly you can look in the syllabus, what it is that you're going to be teaching. You could be talking to the course leader. But clearly you have to know, do I know the content that I'm teaching? And I had some experiences in my education where I had someone that was the clinical teacher, the clinical leader, and they were in the wrong area. It was a nurse that had an expertise in one area, and they said, oh, we don't have anybody to teach this area, so here we want you to cover the intensive care unit. That could be kind of intimidating if that was the community health nurse. Do you know the policies and the procedure for the agency? If you're going to be mentoring a student, if you're a clinical teacher, you have to have spent some time in that hospital and know what those procedures are, know where to find things, know how things are done, if you're going to be able to be of any help at all, any guidance with your students. Do I know what other learning opportunities are available in the agency that you're in? I don't think we ever find a situation that is perfect. And sometimes if you go into a situation that may not be perfect, either the staff is short or everyone's sick or everyone's been discharged, what are you going to do in terms of the 8 hours of learning that you've got for those students? So as much as you know about the area. The other thing is, how do you prepare the area for the students that you're bringing? There is nothing, I think, more devastating to the clinical area is when you bring in a group of students and you've not told them this is their first day in the clinical area. And they barely know how to wash hands or do vital signs. So they need to know what's the level, what's the expectation, what are we going to be expecting these students to do, and what can they expect back from them. Do I understand the expected outcomes? Now that's going to be from the faculty or the preceptor. Do I know what the student wants to accomplish at the end of the day? And that doesn't make any difference what the discipline is. Whether it's the medical student, the radiology student, a dietary student, you all have to know what is it that I want for them to accomplish by the end of the day. And the last, I think, how do I prepare the students? I think we're notorious for making assumptions, and the students are at a loss. We typically will move them from one clinical area to another. Very often, the faculty preceptor, the clinical faculty stays in one place. We become very comfortable. It's kind of a home environment for us. And of course, we know where to find the bathrooms and where to go get a cup of coffee. Students who come in for the first time, sensory overload, and they're absolutely overwhelmed. Most of the time, they're going to be stressed and anxious to start with. So we've got the W's. What do you need to tell them? What do they need to wear? What do they need to bring? What time do they need to be there? What unit do they need to show up on? Where are you going to be? How are they going to get in touch with you? And where to park? Okay, and also the rules of you do not smoke in this facility. You do not smoke out in the parking lot. All of those things. There's nothing worse than to have your clinical area look out in the parking lot and you see that cluster of radiology students. Nurses definitely wouldn't do that. Smoking in the parking lot, because radiology students know what that does. Clinical experiences, the secret of joy in work is contained in one word: excellence. To know how to do something well is to enjoy it. If you want your students to enjoy what they're doing in the clinical area, they want to feel good about what they've done today, that's going to continue to move on. Even if it is the very simplest, very mundane task, to feel good about doing something well the first time goes a long way in terms of that, what we talked about, student motivation. If they're going to feel good about it and they've been motivated on day one, they're going to come back with a different level of enthusiasm for day two. Wise words. Initial learning is temporary. Initial learning is temporary. We know if they hear it one time, the likelihood of retention is not going to be very good. We know that if they're going to be good at what they're doing, they need to have repetition. As the mentors, the preceptors, the faculty instructors, we can't expect proficiency. They've done it one time in a practice lab, they've done it one time in a clinical lab. We can't expect them to be perfect at it the first time around. So the repetition is certainly part of it. Now, I remember having colleagues tell me about what nursing school was like for them when the earth was cooling, and that they had a checklist and they had to do so many mundane skills so many times. So, I mean, I think you can take repetition too far. I mean, I really don't think you have to make up 100 beds to have some proficiency with making up a bed. And I understand that Nursing school used to be like that. I did not go to nursing school when the front was cooling, but I have some friends that did. And we do know that it's imperative that we are providing feedback on the knowledge, skills, and attitudes that we're expecting these students to have. So we've got to give them the feedback on the knowledge that they've acquired, the skills that they're performing, and also their attitude. How do you provide the positive learning environment? We know that if it's a positive environment, you're going to get a better response. And we just heard about the millennium generation. They're all about wanting to get that positive feedback. And I agree with Cindy. Was that her first name, Dr. Price? Christy. Okay. I agree that it really is not just unique to the millennium generation. And a lot of us in healthcare programs find that we have students that are the 18 to the 55-year-olds. So we are engaged in teaching across the board. I don't think this changes. Everyone likes to have things that are positive and reinforcing. How do you do that? Good mnemonic. That the students need to be real clear on expectations. There needs to be accountability, and that accountability can go both ways. Accountability for the preceptor, the clinical faculty, as well as the student, and the R for reinforcement. And let me just talk about that. Expectations. You want to share with that student what I'm expecting to see from you. This is what it's going to take for you to be successful. This is what I expect to see. There doesn't need to be a hidden agenda. They don't need to be doing a scavenger hunt to figure out what is it that I need to do to be successful with this experience. And students must be able to trust your expectations for success. Goes right back to what Dr. Price was saying, is they've got to be able to trust you for what you're saying and that you know what it's going to take to be successful. Tell them again what is expected. The A for accountability, students need to know they're responsible for their own actions. Now I find this is one of the areas that always kind of stands up, causes some problems, that it's someone else's fault, someone else interfered, I lost my book, I lost my cards, the dog ate my lecture, the dog ate my paper. There's always a reason to excuse the fact that they're not doing what they're supposed to do. As healthcare professionals, accountability is imperative. We're going to have people's lives in our hands. They have to be accountable from day one. Now, the accountability may start off small, but there's still going to be accountability. And we do know that learning is a collaborative partnership. And it's not a situation where the preceptor or the clinical instructor is standing with arms folded and say, well, show me what you've got. Clearly, a collaborative effort is involved in terms of tell me what you're doing, tell me what you're planning, let's talk about how you're going to approach this. Clearly, it's collaborative. I don't think it has to be collaborative just from the instructor or the preceptor. Collaboration can also be with fellow students. That is extremely valuable. If you've got a situation that's complex, to have two students teaming a situation is wonderful. And then you get right back to Dr. Price's comment that 90% of the learning, if it's done with peer education, is better. So that goes right along with that. Reinforcement, yeah. Positive and encouraging. The little picture up at the top is that toddler first learning to walk. If you were the parent and your toddler is learning to walk for the first time, we certainly don't chastise them or shame them if they fall down the first time. We pick them up, we put them in the right direction, and we clap and make complete idiots of ourselves when they're taking their first steps. We need to remember that when we're dealing with our clinical students, because they're very much doing the same thing. They're going to be inefficient, ineffective. They may make mistakes, heaven forbid, along the way. But what we want them to know is that we're there with them, we're encouraging them, we're giving them positive reinforcement, and we give them the opportunity to improve. The scary thing about this is students who will say, well, if I make a mistake, do I fail? You know, and that is the horror that goes out there. What if I make a mistake? Will you fail me? I've made one mistake. You're going to fail me. So what do? They don't tell anybody. They hide it. And then it snowballs. Is it something that's going to be detrimental to the patient, detrimental to their outcome? But if you've terrorized your student and they're afraid to say, I'm having problems, I'm not being effective, I've made a medication error, you know, I've done the x-ray in the wrong way, I used the wrong needle, I used the wrong color tube. If they're not willing to share that, then you certainly have lost that moment. Have y'all all had that experience? Where you had the student that you knew needed help and you couldn't find them? And why couldn't you find them? Because they were hiding in the bathroom because they knew the only way to survive the clinical day was to stay out of the way of the instructor? Ugh, how sad. Expectations, accountability, reinforcement. How do you have a successful evaluation? Now, I think number one, you have to think about, when does evaluation start? When do you stop teaching? And when do you start evaluating? Now, you can read a lot of articles about that, a lot of dialogue about how soon do you start the measure of evaluation. And you'll have some instructors that say, we're evaluating from the very beginning. Other programs have said, you know, we're going to give them the first 6 weeks of practice and nothing counts. And then the last 6 weeks, then we start evaluating. How do you feel about that? Do you think we lose teachable moments with that? Yeah, I think so. I think so. I think providing feedback, evaluation versus are you going to give a final grade is how that is interpreted with the student as well as the faculty. Using the mnemonic improve as to how to give successful feedback. And we're going to talk about each one of these. Identify the objectives, make a friendly environment, the pitfalls of feedback, how do we respond to the learners, the objective is a must, validate, and have an established plan. Identify the objectives, I think, is to clarify what your expectations are for the learner. In one of the programs that I have taught in, the brand new first day of clinical, I think they were in class for 10 days, and then we took them into clinical. They didn't know much in 10 days. And we made sure everybody knew, these folks don't know anything about how to wash their hands, take vital signs, and talk to the patient. So we made it real clear to the students. Week 1, this is what you're doing. You're washing your hands, you're taking vital signs, you're talking to the patient, and you're looking at the chart. Week 2, we've had them in class another 5 days, so they've learned a little bit more. Week 2, this is what we expect. Week 3, you're doing this. Week 4, you're doing this. So there was real clear objectives as to what we were expecting those students to do. So we didn't lose anybody by the wayside, and no one was panicked about being in the clinical area because they knew exactly what they were supposed to be doing. Develop those learner-specific objectives and include the expectation in the feedback loop in terms of you are telling them what you expect, and then the feedback is they're going to give you feedback of this is what I was able to do, this is what didn't work, this is what I still need to do. That also goes back to the learner being accountable. If a learner gets through a program and they've never done 1, 2, or 3, and they want to say, well, that program didn't prepare me because I didn't get to do this or this or this, then the question is, well, what did you do to help find that activity or find the ability to do 1, 2, or 3? So certainly back into that feedback loop. Make a friendly feedback environment. Now, Dr. Price would like this. You know, this is the warm and fuzzy caring. How many of you have ever seen in a clinical area that the instructor has chewed out the student in the middle of the hallway or in the middle of the nurse's station around other students so that everyone knew they screwed up? Everybody had that experience? Pitiful. Does that improve the relationship? Does that improve the student's performance? No. That makes them feel like this, and when your tire goes flat, you'll know why. We want to show interest. We want to be concerned. We certainly want to start off with, this is what you've done good today. We want to start off with that positive feedback. And everyone likes positive feedback. Even if you really do mess up, everyone needs to know, well, this is what you've done and been effective. This is what you've done a good job at. But now let me tell you, here is where you need to work. So you're giving them some balanced feedback. You're going to reinforce the good performance. You're going to say, boy, you did a really great job relaxing the patient. Really did good. Now the fact that you made the face that you made so that the family members saw you pucker up and snarl was probably not real good. Good thing is the patient didn't see it, you know, but mom did. So next time, let's work on the poker face. Certainly you want to identify a weakness. You also want to give them some feedback of what they can do to repair it. What can they do to improve? You want to do it immediately, ASAP. Have you ever been in a situation where all of a sudden someone is really angry at you and you haven't a clue? Why are you so angry at me? Well, do you remember last year when you da-da-da-da-da-da-da-da-da-da-da? Sounds like a marital relationship, doesn't it? And you think, oh man, why didn't you tell me when that happened? How many times have I done it since then? Well, gee, no wonder you're angry. Okay, so you want to give immediate feedback. You'll have, if you don't give immediate feedback, they may not remember. They may not believe, I really didn't do that. So immediate feedback, and certainly you want to do it in a private environment. The pitfalls, students who think no news is good news. So if you're not talking and communicating to the student, they're just going to assume everything is wonderful. And that goes right along with that millennium generation. They're just going to assume, well, I thought everything was great. Negative body language. You're angry and the students don't know why, they become afraid of you. Now, I have had students tell me, oh, you really look angry. And I went, no, I'm thinking, and it's very painful. It has nothing to do with you. I'm thinking real hard about da-da-da-da-da-da. And so I apologize that when I'm thinking, the face looks contorted. It's my thing, sorry. I let them know that so that they do not automatically assume that it's all about them. The millennium generation students do. You know, if you had a bad morning, you had a fight, your kids were driving you crazy, you know, you got a ticket on the way to work, you know, you're going to be disgruntled, disheveled, any number of things, and they're quite sure that it has all to do with them. So make sure that you are transparent with that. Not that they want to carry your burden, but you do want to let them know, I'm human too. Snap back, think before you speak. Students are intimidated when you lose your control. This is just like being in a parenting situation. And there are some times when you have students that do things that you just want to grab them by the collar and yank them out of the room. You may not do that. Obviously, you have to go out, you have to count to 10 or 20 or 50 or whatever it takes. And then once you're in control, have the conversation in terms of what's going on. If you're judgmental, you will destroy the student's self-esteem. Back again to the millennium generation. And by judgmental, I don't know whether you have ever had that experience, but would overhear the instructor say, well, if you keep that up, you'll never graduate. Sitting in class, and they say, well, look to your right, look to your left. Neither one of them will be here at the end of the semester. Okay. Making lots of really negative, judgmental statements. Certainly, that's not going to do a lot to build somebody's self-esteem. Well, I lost 5 last semester. Probably going to lose 5 this semester. Step up and let's see if you're going to make it. Responding to the learner's self-assessment. When you're giving that feedback, is to give them an opportunity to tell you what did they do well and where do they think they need help. There is nothing better if they can say, you know, I'm really good at this and I'm really good at this, but where I really think I've got some weakness is taking care of this type of patient or being in this type of environment. Would you try to find me a patient? Can you give me an assignment that will let me focus on my weakness? Now, how many students do you know that are going to feel safe enough to do that? You know, if they're trusting of you, they're certainly going to. But you have to set up that environment to start with. Well, I hope you guys are warm now. Are y'all warm?
Yeah.
Oh, man. Okay.
Is it too warm?
Yeah.
Yeah, I knew when somebody was turning up the heat that I'd be dying by the time this was over. Objectivism is a must. You have to be real clear in terms of where you're going and exactly what you're going to be expecting of a student. You've got to avoid those global judgments. I already talked about that. And anecdotal notes are really critical for an effective clinical instructor or preceptor. Now, when you first start doing a job as a preceptor or a clinical instructor, you remember everything vividly. You probably could account every single patient, every single student. You could probably even remember every med that they gave, every treatment. But it doesn't take long before it all turns into mush. And you really can't remember who was doing what on what day. Anecdotal notes are vital. Personal property of the instructor, and what anecdotal notes need to do is to provide the story behind the situation. Someone ought to be able to read your anecdotal notes and say, yeah, I can absolutely see that occurring. Oh, thank you, I can feel that.
Can you feel it? Okay.
Yes. Some suggestions on the anecdotal notes. Now, this does not have to be something that goes in a student's permanent record. Anecdotal notes are the property of the instructor or the preceptor. And it's of great debate whether anybody could subpoena those anecdotal notes or not. I always encourage people to write them as if they can, because you just never know. But certainly a daily record of what was the student's assignment, what was their learning experience, what were they doing, what was their performance. Needs to be real objective comments and needs to be very detailed so that you can have a picture in your head. Here is the critical piece. You've got to document both the strengths and the weaknesses. You've got to do your anecdotal records on all of your students, not just your weak students. What happens if you only do anecdotal notes on your weak students and only on their negatives, only on their weaknesses? What is the student's comment going to be? Oh, she didn't like me. She had it out for me. I knew I wasn't going to pass from the very get-go. She's been after me the whole time. She kept taking notes about everything that I was doing. And of course, what you want to be able to say is, I take notes about all of my students, what all of my students are doing. So no, it's not you're being picked on. Summarize regularly, weekly. And I think that probably just depends on how much they're in the clinical area. If you've got somebody that's in the clinical area 3 days a week, yeah, probably the summary is probably sufficient. If you've only got them in the clinical area for 6 to 8 hours, 1 day a week, you know, 1 daily note is probably sufficient. And the last one is to relate it to performance objectives. Any course that you're teaching should have real clear performance objectives. This is what we are expecting students to learn. These are the outcomes at the end of this course. Now, as long as you are relating their activities, their performance, what they're doing, you want to tie it in to the course objectives, the clinical objectives. What you don't want to be doing is pulling something out of the air and saying, well, I know that we weren't doing labor and delivery this semester, and that you really haven't learned that content yet, but that happened to be the patient that you were taking care of, and the fact that you blew it, da-da-da-da-da-da-da-da. Not fair. Not fair. And you have to be fair and reasonable. Now, do you expect them certainly to be able to take vital signs and know how to wash their hands and give it medications? To any patient at this point, yeah, but maybe knowing the nuances of a precept delivery, maybe not. So make sure that you're relating it to the objectives of the course. Examples of an anecdotal note. The correct way, the student was unable to identify the correct location to administer an IM injection for an underweight 80-year-old. Is that a real visual picture? You know exactly what was going on? What you don't want your anecdotal notes to say is the stupid student doesn't know where to give an IM injection. Now you can see that would be pretty liable comments, and of course invariably you've left your notebook somewhere, turned to that page, and the student read it. You know, that's exactly what would happen, right? So do you ever want to write something like that down? No. Now, if you feel that way, what you might want to do is just go into the bathroom and just, you know, if that helps you relieve your tension. But certainly you're not going to write liable statements like that. The V for validate, encourage the positive behavior. Always that encouragement, all of that positive. Suggest alternatives if the performance is weak. Clearly, to stay on legal ground, you give them the opportunity to repeat. We don't fail students for making one mistake. You give them the opportunity to repeat. Now don't ask me, well, what if the mistake ended up killing the patient? I'm not even going to go there. Hopefully there are enough safety nets that we don't run into that. Of course, in the simulation lab, we have a nice way of allowing that experience to occur. Establish a plan if changes are needed. You want to give the student real clear instructions as to what they need to do if their performance is not up to par. My last little note is to always make sure that you've got a grievance policy. If you're giving students negative feedback, and know that the students have rights that we have to follow it. So not only are the faculty or the preceptors going to be knowledgeable about what is the grievance policy, but the students need to be aware of it as well. And what you don't want to do is deviate from it. You want to stay letter of the law with that. Okay, so this is what we went through with Improve. And I'm a firm believer that you want to set up as positive a learning environment as you can so you don't have to deal with the unsatisfactory performance. But we know that's not the case, don't we? We know that there's always that dreaded scenario of when the student's performance is not up to par. And you get to a point where you've got this is a pending clinical failure. STAR is a good way to think about how are you going to organize your conversation and your feedback with your students. Now, I am in a situation where you say, okay, week 2, this was the problem. Here were their strengths, here was their weakness. Week 3, they still have the weakness. Week 4, we're in trouble. You're going to call them in and you're going to say, this is the situation. You're going to describe in detail that you have had 3 weeks for performance and you're not showing any improvement. The task, this is what you should have been doing. This is what other students were doing and were able to do successfully. So what is being expected of you is no different than what's being expected for the rest of the students in this course. What do you need to do to improve? 1, 2, 3. This is what you need to do. What are the consequences if you don't? And what is the time frame for meeting that? Okay, you have blown it. 3 weeks, you have had lousy performance in the clinical area for all of these reasons. And as the clinical preceptor, faculty, this is what I'm going to do to give you an opportunity. What did Dr. Price call it? Makeup work. This is what I'm going to do to give you an opportunity to reprieve those 3 lousy weeks. And by the end of week 5, you need to have done 1, 2, 3, 4, and 5. Very clear, very spelled out with a very clear time frame. And then the results then are what were the actions? What occurred? Were they able to meet that performance? You're going to want to have a conversation with the student. And that is a face-to-face conversation. Now, at the end of week 3, when they've blown it, you're going to take them to the side and say, we need to have a conversation. When is a time where you can meet with me privately and we can discuss what's going on with your clinical performance? So you're going to go ahead and tell them, we've got a problem with your clinical performance. And so let's set up a time. You're going to complete the STAR form. As the faculty or the preceptor, you're going to have to think, what's the situation? What's the problem? What should they have been doing? You want a neutral party or a course coordinator to take a review of it. If you're a new faculty, absolutely that is vital. But you want somebody to look over this that's teaching in the same course and say, are you agreeing? Are you seeing? Am I missing anything? You want to meet with a student. You want a witness. You want to explain the process before you start the discussion. You want to explain why you've got a witness there. We didn't used to have to do that, but it's gotten, everything is so litigious. You are just in a much safer place. Now, my recommendation for that witness is they truly sit there and say nothing. What you don't want is for the situation to be 2 against 1. And so clearly the witness is there just for observation, not to say, oh, well, yeah, she's right, yeah, okay? Doesn't need to be 2 against 1. So clearly the witness is only there. Typically, if you're telling a student that they're not performing, that they are pending, going to fail clinical, they're going to get emotional, and it may be very appropriate that you say, why don't we take a 5-minute break? Let them go to the bathroom, cry, scream, kick, whatever they need to do to release their stress, and then they can come back and listen. You know how it is if you're stressed out and someone's telling you bad news, you don't hear it. All of a sudden, your head turns into cotton, and they sound like wah, 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 and you don't hear what's going on. The students are in the same situation, so give them a break. Let them come back, let them add any information. Now, what's wonderful is that they can add information, give you a different perspective, and say, oh, I didn't know that was going on. It may change the situation, but you do want the student to have the opportunity to add any information they want to. Reassess the conversation. If new information changes the outcome, then by all means change the outcome. Do not feel like you've put yourself in a box if you didn't have all the information. Make sure you get signatures, date, and time, because they'll say, I never had that conversation. I never saw this piece of paper. I never knew I had to do that. I didn't know I had a deadline. I didn't know there were consequences, okay? And you think, wait a minute, you said in my office, we had the conversation, I didn't do that. And then they go tell the dean, she didn't do that, she didn't say that, he didn't do that. Signatures, date, time, the instructor and the witness. And what you do is you're playing protection. Dismissing clinical students for deficiencies. We know that we have a legal obligation to make sure that they are performing where they should be and their performance is safe. I can't think of anything worse in education is having to fail a student for unsatisfactory clinical performance. I absolutely detest it. I would rather do cartwheels with that student. I would rather spend extra hours improving their performance and efficiency than have to go to a clinical failure. It is miserable. The faculty, the preceptor loses sleep, and you've ruined the student's life and their parents' life and their kids' life and everybody else's life, and you're the bad guy. And so, you know, it is a tough situation. You want the student to know that you are on their side and that you are working with them to be successful. But you can't not fail them for fear of litigation. And that is a scary thing. And I know everybody has probably had an experience where someone has passed a student on, didn't meet the objectives, really hadn't hit the level where they were supposed to, and then all of a sudden you have them, and it's kind of like, what do you mean? You don't know how to do this and this and this. Those were performance objectives at the end of the last course. And we're into the next level course, and you're still not doing those. And then you go back and you find your weenie fellow clinical instructor doesn't have the gumption to do what they need to do. Now that's maybe not necessarily to fail them, but it's to give them negative feedback. How many of us like to give people negative feedback? We don't. And so you're going to find that some people will avoid that at all costs. They get labeled if you've worked with people like that for a period of time. You kind of know, well, I know that they won't ever give a negative evaluation. What I want to say here is we do have judicial deference in that the courts expect us to be experts and make decisions about performance. This will never go to court and be overturned. You are never going to be sued in civil court as long as you do the things that you're supposed to do. The courts are not going to get involved with, are you safe or are you unsafe? It will never occur as long as the procedure, the only time they will is if the procedure is unfair or there's no due process. If the student did not have the opportunity to express their voice and be heard, if you didn't go through the grievance policy correctly, if you didn't follow your own policy, then they're going to side on the student. But as long as you are providing them due process and you're following your own guidelines, you are safe. It will hold up in court. If there's anything that you're doing that's arbitrary or capricious, these are willful, unreasonable, and without regard to facts. I just don't like you. I don't like the way you look. I don't like the way you talk. I'm just failing you. Arbitrary, capricious. Allowing one group of students to do something and not another. Let everybody else turn their paper in late, but tell this student, no, yours has to be turned in on time, and if it's not on time, you lose 20 points and you fail. Giving exceptions only for some students. If you have a student that is in a clinical deficiency, you have to give them notice. You got to tell them you got a problem. You got to give them the consequences. What's going to happen if you don't perform? And you have to give them suggestions for improvement. That's it. And if they don't improve, if they don't reach the consequences, then you are upheld. There's a couple of court cases. This was 1978. Horowitz, Board of Curators, University of Missouri versus Horowitz. This was a medical student. She had, I think it was a she, I'm not sure. The medical student had multiple problems, multiple documentations, multiple faculty all said that the clinical performance was not up to par. The student had been notified, she had been given additional opportunities. They upheld it and said, no, we're not going to touch that. Now the sad news is she made straight A's in all of her other courses. So textbook, she was great. Disaster in the clinical area. The courts upheld it. Sylvester versus Texas. This was a second-year law student, got a grade of a D, went through the university's appeal process. The university ignored the appeals process, did not let it process accordingly. The professor refused to go to a conference and try to mediate, so they violated the student's right to due process. Guess what? Texas lost. And they lost because the university didn't do what they said they were going to do with a grade grievance, and violated their own policy. Other than that, you're not going to find a court that's going to overturn our right and responsibility to make clinical decisions, as long as we're doing them right. Comment: the joy of clinical teaching and student learning depends on the ability to provide and accept effective feedback performance. Assigning the grades are never easy. Assigning the failing grade is even harder. And I always like to go the easy way. Prepare them well, teach them well, be a strong teacher, and hope you don't have to deal with clinical failures. Any questions, comments?
Thank you.